So I will speak now about extravascular water, which is another variable useful to treat patients in ICUs. First of all, I want to declare that a member of the Medical Advisory Board of Pulsion, which is now getting a group. What is extravascular water? EVLW. In fact, it is the amount of pulmonary edema, and the normal value is supposed to be less than 10 ml per kilogram. The second question is how to quantify extravascular water. Can we use auscultation? Can we use chest X-ray? There is an interesting study comparing the value of auscultation and chest X-ray compared to a reference method, which was lung computed tomography. And in this paper, the value of auscultation was very poor, essentially with a poor sensitivity, only 34% to detect pulmonary edema. For chest radiography, also, the sensitivity was not good, 60%. The specificity was good, but overall, the accuracy was not very, very acceptable. So we need other tests, other methods. What about lung ultrasounds? You know that it becomes more and more popular. And if you use lung ultrasounds, you should pay attention to the presence of B lines. And there are some studies comparing the presence of B lines and the value of extravascular water. Here, lung water was measured using transpulmonary thermodilution on the y-axis. And on the x-axis, you have the ultrasound score, which is a score which was developed to quantify the presence of B lines. As you can observe, there is a nice correlation, and the authors are very happy with this correlation. And they said in their title, excellent prediction. I disagree. If I put the line here, which is possible, the data are the data. For the same value of lung water, 10 here, I have different ultrasound scores. So personally, I cannot rely on this presence of B line to quantify the pulmonary edema. So it is more qualitative than quantitative marker of lung edema. We can do better. We can do better if we directly measure extravascular water using the transpulmonary thermodilution systems. I don't want to go into details for the methodology. It could be boring. Just to remind you that if you use a system, this system, you have to inject a cold bolus into the right atrium, and there is a dilution of this cold bolus in the vasculature, first in the right atrium, after the right ventricle, the lung compartment, left atrium, left ventricle, and the changes in temperature produced by this cold bolus injection are detected at the level of the femoral artery using a catheter equipped with a thermistor. And the device is able to construct a thermodilution curve exactly as for the PA catheter. And from this curve, it is possible to estimate cardiac output, but not only cardiac output. You also can, the machine can, not you. It is automatically done by the machine. The machine can pay attention to the mean transit time, MTT, and the downslope time, DST. And using all these variables, it is possible to obtain extravascular lung water. If you use a PICO system, this is this formula, using the downslope time. If you use a volume view system, which is another one, the downslope time is not used, but they prefer to use this maximal upslope and maximal downslope, and from these slopes, they can derive the global and diastolic volume and the value of extravascular lung water. What about validation? There are some papers which directly validated extravascular lung water. In animals, for example, this is a very nice study comparing extravascular lung water measured by the PICO, Transpulmonary Thermodilution system, and by gravimetry, which is the reference method in animals. But of course, I said in animals because you need to kill the animal at the end of the experiment. So, of course, you can do this in men, but it's not very fair. So in animals, in this study, the authors compared both values of extravascular lung water in conditions of normal lung water as well as in conditions of high lung waters, because they produce some pulmonary edema in these animals, and as you can observe, the correlation was excellent. In humans, there are some validation studies. For example, this one coming from Japan, and they measured extravascular lung water by the PICO just before the death of the patient, in moribund patients. And after the death, they took the lungs, and after desiccation, etc., they weighed the lung, and they measured the post-mortem lung weight. And as you can observe, there was a nice correlation between lung water before the death and post-mortem lung weight after the death. And the same team, the same group in Japan, also pay attention to the presence of diffuse alveolar damage, which is a marker of pulmonary edema, at autopsy of patients just dead. And they measure lung water before the death, again, in moribund patients, of course. And they obtain good results. Patients with no DAD had a lung water, value of lung water, which was not high. Patients with DAD had high value of lung water before the death. So there is a link between extravascular lung water measured by thermodilution and the presence of diffuse alveolar damage in the lungs. And they perform ROC curves, and they obtain good results, and a cutoff value of 10 ml per kilogram for lung water. This is exactly the value which was predicted by some algorithms before. So 10 is a cutoff found in this study. Also, there are some indirect validation studies. For example, this coming from our group in Bicêtre Hospital in France, and we included 200 patients with severe ARDS and a high mortality rate. And after a multivariate analysis, we observed that the maximal value of extravascular lung water measured during the stay of the patient was an independent predictor of mortality. So this is an indirect validation of this variable. And this was confirmed by the group of Michael Mathey, showing that extravascular lung water measured by the PICO here also is an independent factor associated with mortality. Of course, there are limitations to use this value, and we can expect a poor distribution of the thermic indicator in non-homogeneous ARDS. And this could lead to some underestimation of extravascular lung water. But in real practice, it does not matter. This is a study by the group of Antonio Pesenti from Italy, comparing extravascular water with quantitative computed tomography, which is a reference method here, in ARDS patients. And they found very good results, nice correlation, 0.9, and good agreement using the Blunt-Altman analysis. So we can say that even in ARDS patients, lung water is still valid. And this is confirmed in this review of the literature we did with Mathieu Josviak and Xavier Monet. And we found that many studies showed that extravascular water was an independent predictor of mortality in ICU patients, in general ICU patients, as well as in severe septic patients, as well as ARDS patients. And again, a study from Japan, and Takashi Tagami as the first author, showing that in ARDS patients, survivors exhibited a decrease in extravascular water over time, while non-survivors did not. And a value of 2.8 for this decrease was found as predictive. But in practice, how to use extravascular water at the bedside? In critical patients, it can be useful to identify patients with pulmonary edema. Sometimes the diagnosis of pulmonary edema is difficult to do in mechanically ventilated patients, for example, sometimes. And lung water can be helpful. And I took this example of weaning from mechanical ventilation. You know that sometimes a pulmonary edema occurs during the weaning process, and so not easy to detect and to clearly detect compared to other causes of weaning failure. And one way to do is to measure lung water in a patient with transpulmonary thermodilution devices in place, of course. And in this study with Martin Ress, we showed that the changes in extravascular lung water during a weaning trial was very accurate to predict the presence of pulmonary edema during weaning. And we detected the presence of pulmonary edema during weaning using a PA catheter and an increase in the wedge pressure. So the area under the curve is good, 0.89, and we had two cutoff values, 6% and 14%. One was good for sensitivity, and one was good for specificity. And also, the increase in lung water is very fast. Very fast. And to prove this with Martin Ress and Xavier Monet, we did an original study. We used bronchoalveolar lavage in patients. And by definition, by bronchoalveolar lavage, you produce some increase in extravascular lung water because you put some fluid in the lungs. And lung water was able, extravascular lung water was able to detect very quickly the presence of lung water easily. And after 30 minutes after the bronchoalveolar lavage, there is already a marked increase in lung water. As you can see, the evolution of lung water was a decline, of course, but it took time to return to baseline. So when you perform a bronchoalveolar lavage, it takes maybe 4 hours to totally recover. The second way to use is to diagnose, to identify hydrostatic versus increased permeability pulmonary edema, not with lung water alone, but with a derived parameter, which is pulmonary vascular permeability index, PVPI, which is a marker of lung capillary leak. And this is a ratio of extravascular lung water divided by pulmonary blood volume. And it is automatically calculated by the system. You have nothing to do. Just injection of cold bolus. And in this study with Xavier Monet, we tried to identify patients with ARDS and patients with hydrostatic edema using PVPI. And we succeeded to do. As you can observe, we had a clear distinction between the two categories of edema, and a value of 3 was the best predictor. Above 3, you have more chance to have a patient with ARDS, and below 3, a patient with hydrostatic edema. And this is better than the famous biomarker, which is BNP, to predict the presence of hydrostatic edema. And this is confirmed by a study performed in Japan, again, where the authors found that PVPI was higher in ARDS compared to cardiogenic edema, it is logical, and also compared to pleural effusions with atelectasis. And they found a cutoff value of 2.85, very close to the value we found in our study. And also, this works very well if you take the definition, the Berlin definition of ARDS. You can observe that in case of severe ARDS, PVPI is higher than in cases moderate ARDS and mild ARDS. And also, in this study we did with Mathieu Josviak and Xavier Monet, we found that the maximal value of PVPI obtained during the stay of the patient was an independent predictor of mortality. So it makes sense to pay attention to PVPI. And also in this study, the authors show that the peak values of lung water and PVPI measured during and immediately after surgery predicted post-operative ARDS. So you can anticipate during surgery the presence of complications after surgery. And of course, we can use extravascular lung water in patients with ARDS and also in the general population of patients to guide fluid therapy. Because lung water here can be taken as an indicator of lung tolerance to fluid infusion. This is a whole study by the group of Daniel Schuster. They compared in a randomized fashion two groups of patients. Patients managed according to PAOP, wedge pressure, and patients managed according to extravascular lung water. And as you can observe, the cumulative fluid balance was better maintained in the group of patients managed according to lung water. But more importantly, the duration of mechanical ventilation and the duration of ICU stay were shorter in patients managed according to extravascular lung water. In fact, if you use this, and if you give fluids, in case of normal lung capillary permeability, you can increase hydrostatic pressure by giving fluids from 12 to 15, for example, and nothing happens in terms of lung water. But in case of increased capillary permeability, the same increase in capillary pressure from 12 to 15 results in a huge increase in lung water. So the value of PVPI can give you the slope of the increase in lung water. So in my opinion, lung water is very interesting because it is also integrated in a helpful system for guiding fluid management, especially in patients with ARDS and circulatory shock, because you can well assess the fluid infusion benefit-risk ratio. For the benefit, the numerator, you can rely on PPV and SVV if applicable, or pulse control cardiac output response to passive lag raising. This is for the prediction of fluid responsiveness. This is the numerator of this benefit-risk ratio. And for the denominator, for the risk, you can pay attention to extravascular lung water and PVPI for assessing lung tolerance to fluid infusion. So it is very useful because you have these parameters to make the decision to start, to continue, or to stop fluid infusion. Thank you very much.